And I'll be just telling you the idea about how the EEG will be helpful in making a diagnosis and how it won't be helpful in diagnosis. Just see this video. This is just a starter. You can just see what it is and what will be your investigation. So this I will come later. All of you can think about it. Okay. Similarly, I will show you one more. Just see this also. Again, what is it? What will be your investigation? Okay. Okay. Keep both in your mind. I'll be coming back to these videos later. Okay. Now we have the aims of our today's talk to understand the usefulness and limitations of EEG in the investigation of seizure, to understand the hazards of wrong interpretation of an EEG, and when to request an EEG appropriate. So this will be our aim. Just 3 points. Understand that EEG is not a diagnostic test. For that matter, I think most of the investigations are like only. And you must understand that in children without epilepsy, 33% can have an abnormality, and 5% have real epileptic abnormalities also. And again, in an epilepsy patient, 13 to 59% have an epileptic abnormality on first standard. That's all, 13 to 59. And understand that 40% have a normal EEG. So that is why I told you that EEG is not a diagnostic test. And so I'll start with the history. This is all of you know. Rashmi, she is 2-year-old, was brought to the ED with the following history. Her mother was in the kitchen when she heard a screaming. She rushed back to the living room, and in her own words, she was still all over. Her eyes were rolled upwards and her breathing was shallow. I went to pick her up and she began to shake all over. It lasted 5 minutes, and afterwards she fell asleep. Temperature taken at home was only 37.5 degrees Celsius. And she had a 12-hour history of a runny nose and fever earlier, but now you would have seen the temperature. She had similar attack at 1 year. Her grandmother is a known epileptic from 2 years of age, and the mother had a history of febrile convulsion. I think, Abhiram, you can unmute either yourself or Bennett. And what will be your idea about this case, and will you do an EEG or not?
Sir, we can ask people to send a reply in chat.
Okay, they'll be sending, but just your suggestion also. An EEG or no EEG? See, because of this, there is a family history of epilepsy, and there is no fever. So what is your impression? Will you do an EEG with this background?
In the first episode, it may not be very good to have a EEG.
That's it. Because as I have mentioned, this case is an febrile convulsion. Even though at the time of recording, at the time of seizure, there was no fever, but child was having fever, and there would have been fever, which is not recorded at that time. So that means there is no role of EEG in febrile convulsion. So you must understand that again, febrile convulsion diagnosis is by history and circumstances. Just because of grandmother or the father has an epilepsy, it doesn't mean that child will be having epilepsy. So it will be still febrile convulsion. Okay. Now we'll go to the next scenario. 3-year-old Surya had 2 episodes. First episode occurred 6 months back. She ran to mother for a cuddle, but as mom picked her up, she became pale and floppy, briefly stiffened, then had a generalized jerking for a minute. Then she went to sleep. Okay, then she had the current episode, which was 3 weeks prior to the consultation. Surya had another similar episode when she went out playing in the playground. Loss of consciousness, uprolling of eyes, stiffening, and a normal birth and development history, no family history of epilepsy, no history of febrile illness around the episode, neurology examination normal. What will be your approach? I think others can give the their suggestions. And what about Bennett or Abhiram? One of you.
I feel that this time this is the second episode. We have to do EEG. That is what my feeling.
Okay. Oh, that is you won't do anything else. Here's the history I have given here. I think most important step here is you ask the child. Have you taken any history from the child? No, we are all forgetting that. We must ask the child how it has happened, or was there anything before that? Okay. So according to Surya, she had a tripping and banged her head, but stood up immediately and continued to play for about 30 seconds before having the event. Now, what is your opinion? Okay, unmute and just anybody. Abhiram, unmute one person and they can answer. Okay, will you do an EEG or not an EEG at this juncture? Okay, so because of this history, I will say that it's only a reflex anoxic seizure and not an epilepsy. But anyway, so that means you don't have to do the EEG, just reassure. But with the same history, except that there is a family history of childhood epilepsy in Surya's first cousin. Surya's mother had a couple of febrile convulsions as a child. So what will be your opinion, EEG or no EEG this time? In spite of this history, still our diagnosis is that is syncope, following which there is a reflex seizure, no EEG. But anyway, so here EEG is normal, and it was done at that time. And you see that EEG, it should not be reported as normal, because this may be reported as abnormal, because we can see there are a lot of high amplitude discharges. But these are all okay, this is there, so you can see that there. Okay, so this is a normal EEG. The same child, suppose another person has seen the child, and the EEG was reported, because somebody else also may see the EEG from the EEG lab, and report describes a couple of generalized spike-based bursts in drowsiness. Is it suggestive of an epilepsy, or what will be your approach? And this is the EEG. You can see the EEG there. Just see the EEG. Here again, you must understand that this C4, P4, these are all vortex waves. C is C4, central vortex. Again, C3. So it's mainly arising from the vortex area, and this is what is called as a hypnic burst or a hypnagogue hypersynchrony. Again, it is a normal one. That means our history, our diagnosis of the reflex anoxic seizure or syncope stands till now. So there was no need for any EEG. Okay, so that's it. Now we will go to the next child. He is 10-year-old Sunil. Early morning GTCS, one episode. The child slept by 12 midnight only, because they had a late night program last night. Will you do an EEG here or not? Again, anybody? Will you do an EEG? Okay.
First episode or second episode, I like that we have to be asked.
This is first episode. This is first episode, early morning seizure. Okay, first episode. What will your suggestion?
We don't do EEG.
Yes, that may be actually that is the correct thinking. But recently, because of the ILAE recommendations, suppose certain situation in this case, because there's an early morning seizure, so we have to ask for something else, if there is something additionally there or not. That will decide our need for an EEG. And see this video there, because I have asked the child to do a hyperventilation and see what has happened after the hyperventilation. So he is hyperventilating, and just see what is happening there. Okay, so that means hyperventilation has brought in a seizure, and this is an absent seizure, but with some automatisms also. So will you do an EEG this time? Definitely, isn't it? EEG this time we have to do an EEG, and EEG will help us in at least certain situations. So here, after hyperventilation, you are seeing a very typical 3 per second spike and wave activity. See, this is 1 second. and you are seeing the 3 per second spike and V activity. So diagnosis, because being a 10-year-old child, we will make a diagnosis of juvenile absence here. And we have done a photic stimulation. Photic stimulation did not show anything. So that means here the EEG has helped us confirm juvenile absence epilepsy, and there is no photoconvulsive sensitiveness. So that means this child will require sodium valproate continuously for you may have to do a repeat EEG after the starting of medicines, maybe after 6 months also, to see the responsiveness. And now we will go to our first situation. Anybody has given the some suggestions, Abhiram, in the chat box or the question box? Okay, I'll show you this. What is this? And what will be your investigation? Here, actually, she was doing a Valsalva maneuver. They are volunteers, and she developed a syncope and fell down, and you would have seen a convulsion, isn't it? Convulsion also have seen. You have seen it. But again, what will be your investigation of choice here? See, just watch once again. See, there is a tonic.
Video freeze ആയോ?
Freeze ആയി സാറേ. അത്
വീഡിയോ ഇല്ല, വീഡിയോ കിട്ടണില്ല.
വീഡിയോ കിട്ടുന്നില്ല.
സൗണ്ടും ഇല്ല കുഞ്ഞു സാറിന്റെ.
കുഞ്ഞു സാറിന്റെ സൗണ്ടും കിട്ടുന്നില്ല.
All participants can unmute themselves and answer questions if they want, but they need to mute it afterwards.
Stuck ആയോ പ്രവീണേ?
Kunju sir will come back. കുഴപ്പമില്ല. സാർ ഒന്ന് എക്സിറ്റ് ചെയ്തിട്ട് തിരിച്ചു വരും.
ക്വസ്റ്റ്യൻസ് ഉള്ളത് ചാറ്റിൽ എഴുതിയാലോ മതി? ഇപ്പം സാർ വരുമ്പോഴത്തേക്കും റീഡ് ചെയ്താൽ മതി.
സാറിന്റെ മോൻ കാണുന്നില്ല. ഹലോ,
സ്ലൈഡ് കാണാം സാറിന്റെ?
അല്ല, ഇത് പക്ഷെ ഈജി അല്ലേ ഇത്? അല്ലേ, സാറിന്റെ സൗണ്ട് കേൾക്കുന്നില്ല അഭിരാമേ.
ഇപ്പൊ കേൾക്കാം.
സാറിന്റെ സൗണ്ട് തുടങ്ങി.
Okay, it is ECG now. So ECG you have to do and look for the QT interval, and I think nowadays QT interval is very, very important because of the hydroxychloroquine also. I think again you must remember that as far as possible in these days of COVID, try to avoid doing EEG, because see, whenever in a child we are trying to do an EEG, most of the time we'll be giving a pedicloryl, or now pedicloryl is not available. We'll be giving Phenergan or something, and usually children will be crying, so there will be a lot of aerosol distribution, and this is a closed AC room, so better not to do, and go for a ECG here and calculate the QT interval. I think all of you know how to calculate the QT interval, and the abnormal means it is more than 0.49 seconds, and for a prolonged QT interval, long QT syndrome. So this again, so those who are the syncopes, that is also no EEG is required in that situation, and we will go for a ECG. And when will you do an EEG? So already we have understood that when you have a definite diagnosis, clinical diagnosis, following or a second epileptic seizure, and sometimes following a first epileptic seizure under certain circumstances, like say for example nocturnal seizure of a child with the benign romantic epilepsy. And in defined situation, for example, a child with epileptic spasm, definitely we'll have to do an EEG to see whether it is a hypsarrhythmia or not. So, and in staring episode, that may be epileptic seizure. So our aim must be to diagnose seizure before doing an EEG. And remember that an EEG should only be requested after careful clinical evaluation with a by the doctor with expertise in childhood epilepsy. And the recording and interpretation of pediatric EEG should be undertaken by a department familiar with childhood EEG and childhood epilepsy syndromes. So this is actually the nice recommendation. And again, as I have understood, because if you are doing an unnecessary EEG, that as we have seen earlier, abnormal recording reports you will get, and misdiagnosis, falsely diagnosing epilepsy in a child without epilepsy, and not diagnosing epilepsy in a child with epilepsy also can occur if you don't take a history correctly and miss the correct alternative diagnosis. For example, long QT interval syndrome. The cardiac death itself can happen. And you know that when you are diagnosing epilepsy in a non-epilepsy patient, social and educational stigma. So I think, so finally, what was this diagnosis? Here again, the history was crying just before the child gone into a stage. This again is a breath holding cyanotic. You can see that the cyanosis there. So it is only a cyanotic spell. So that means to summarize, EEG is not a diagnostic test. EEG is useful in children with a clinical diagnosis of epilepsy, and there are significant implications to a misdiagnosis of epilepsy. In the recording and interpretation of a pediatric epilepsy, EEG should be undertaken by a department familiar with epilepsy and EEG. I think I am concluding here, and I took only 16 minutes. Okay, I think I'll conclude here. Questions are you taking now or later?
Thank you, sir. We have a couple of minutes for taking questions. If anybody wants to take answer, 1 or 2 questions we can have, sir.
Okay. I think I'll stop sharing my screen.
Yeah, that is fine.
Okay.
Any participant who wants to ask a question can unmute themselves and ask. Or they can put it in chat.
Chat, only one, no question? Has anybody any question? If
no questions, we will take it in the end. I think Zulfiker is ready. We will go to the next talk. And sir, Zulfiker sir?
Yes, I can hear. Can you hear me?
Yeah.
Yeah. So we are starting.
I think I'll just give a small introduction and then you can start.
I see. Thank you.
Zulfiker sir needs no introduction.
Okay.
He is the doyen of pediatric cardiology and the almost permanent president of pediatric cardiology chapter in Kerala. And he is the teacher of almost all the pediatric cardiologists we have. And I think he does not need any introduction, and his slides will be full of pictures and these things. And I think you can start, sir. We'll take questions afterwards.
Yeah, thank you. See, there are certain words, terms like doyens and excellence, etc., are used very casually these days. But I think as far as the term excellent is concerned, can you hear me now?
Yes, sir, we can hear.
Yeah. When excellence is concerned, I think one situation which is righteously can be called as an excellent idea is the Bennett idea of a questions being asked and being answered rather than the regular talk. So I am very happy to be associated with this, even though I am what you call as a member of IAP. So a triad of questions are being asked and being answered, of course. Now we have a situation where you have a cardiac murmur in the young, and the question is, should we do an echo always? And this is him. Give me a calm and thankful heart from every murmur free. And nowadays we had also called for a COVID-free situation also. Now, murmur is the most common cause for a referral to a pediatric cardiology from the pediatric community. We all know that. And Lene described the murmur as a bellow sound of the heart, frequently accompanying an organic affliction of this organ. And the modern definition is a little more scientific and is longer and very difficult to what you call as learn this. But basically, it's all about vibration in a medium, or that is blood. So now the question is, what is the use of murmur anyway? One, you have to suspect a structural heart disease. Next, once you do that, then you make an anatomical diagnosis, and finally you assess the severity of this particular affliction. Now, this is basic, let's say, final year MBBS thing. We should have a very clear idea about what is a systolic murmur and what is a diastolic murmur. We have 4 types of systolic murmur. One is the murmur which starts little after the first heart sound and ends before the second heart sound, which we call as a mid-systolic murmur because of the peaking in the mid-systolic. It is also called as ejection systolic murmur because it occurs in ejection. Then you have an early systolic murmur which starts from the first heart sound, which we call as a S1 coincident murmur. Then you have another murmur which only occurs late in the systole, which is called as a late systolic murmur. And of course, the very common pan-systolic murmur in a VSD. So there are 4 types of murmur: early, mid, late, and pan-systolic murmur. Similarly, we will have again in the diastole, simple, an early diastolic murmur, a mid diastolic murmur, a late diastolic murmur, and of course, sometimes, rarely, you will get a pan-diastolic murmur, rather unusual in children. And you also get a continuous murmur where the murmur will start from the somewhere in systole and ends in diastole without any impedance. Now, this I think is basically the quick way of looking at whether we have assessed a particular murmur. For example, you decide whether it is systolic, diastolic, or a continuous murmur. Then where is it? Is it in the early part, mid part, late part, or is it a pan-systolic? You grade according to Levine up to 6, both systolic murmur as well as diastolic murmur, and look at the length of the murmur, pitch of the murmur, quality like rumbling nature, etc. Where is it maximally heard, and where does it conduct like axilla, and various maneuvers. And of course, there are certain interesting historical names given to certain murmurs which are of great importance to the people who like history in medicine. So when you have a murmur in a newborn or an infant or a child, that particular person will be either asymptomatic or symptomatic. So look at neonate, whether with symptoms or without symptoms, the usual murmurs within the first 1 day would be valvular lesion, either the stenosis of the semilunar valve or a regurgitation of the AV valve. Then beyond 12 hours, maybe 1 day, you will have a small shunt lesions, tetralogy-like conditions, etc. And later on, you will have regular shunts, stenotic lesions, and other various congenital cyanotic heart disease. And of course, in infants, you have the full picture. You will have shunt lesions, both pre-tricuspid and post-tricuspid. You have stenotic lesions, you have cyanotic lesions, and slowly acquired heart disease also will come into the picture. And also in childhood also, you will have stenotic lesions, shunt lesions, cyanotic lesions, and many acquired heart lesions like rheumatic heart disease, cardiomyopathy, etc. Now, if you have a symptomatic murmur, things are very easy because this symptom can be very critical, like in shock or cyanosis or heart failure. It can also be a significant cardiac symptom like chest pain, palpitation, or a syncope, or a non-cardiac symptom, failure to thrive, recurrent infections, or a syndromic child coming with a murmur. Naturally, we call it as a murmur which probably requires a full evaluation. And the murmur, especially with shock, cyanosis, and heart failure, would require immediate complete evaluation of a murmur. But if you have a asymptomatic murmur in infants and childhood, things are a little different because some of them can be innocent, some of them can be pathological. And the question is, what kind of pathology? Is it a critical abnormality or a less critical? Because even if you miss a less critical abnormality, another better person will pick up this. Now, no harm will be done to the child. Whereas if you miss a critical lesion, naturally, there's a problem. So once you make a diagnosis of a particular pathology, you have to counsel, you have to manage, and of course, follow with or without intervention. At this point, I think we should be very clear about innocent murmurs, because generally many of us consider innocent murmurs as a sort of a waste paper basket. That is, you make a diagnosis of a particular condition that is not so, you call it as innocent. It's not like there are specific innocent murmurs, and the most common innocent murmur is a Still's murmur, which is heard at the left lower sternal border, medial to the apex. Grade is 1 to 3, nothing more than that. It's a musical murmur, short murmur, and decreases on standing. This is the commonest. The number 2 murmur in children is in older children, left upper sternal border murmur, blowing quality, non-musical, again up to 3 grade, again reduces on standing. So both innocent murmurs will reduce on standing. And the third important murmur would be soft blowing, a continuous murmur in the either on the right side or on the left side of the sternum, the upper part, and there is no peaking around second sound as in the regular continuous murmur, and that would be a venous hum. And you must remember that these 3 murmurs, Still's murmur, innocent pulmonary murmur, and a venous hum, can have differential diagnosis, and some of them can be important also. For example, a musical murmur can be due to hypertrophic cardiomyopathy. What we thought of an innocent pulmonary murmur may be due to a moderate atrial septal defect. What we think as a venous hum may be a coronary AV fistula, which would produce ischemia at some point of time. So these are also very, very important. So the magnitude of this innocent murmur can be even half of infancy will have some sort of a murmur, maybe a little more on school age, and it has definitely has an impact, especially if the parents are concerned regarding activity, sports, parental anxiety. They're all very important. And these 4 questions invariably will crop up when you interview with the parents. That is, do they disappear? May not, but no harm will be done. Do they need follow-up? You don't need a follow-up. And do they need an IE prophylaxis? Of course not. And last question they will be asking you, have you missed something? So that probably prompts a pediatric cardiologist to do an echo, even though you feel that it is a genuine innocent murmur, because these questions are sometimes very difficult and they are actually have to be answered very promptly. So if you have a murmur detected, if there is no symptom, or if there is some symptoms, you look at various physiological disturbance, and then you use various tools starting from the stethoscope, chest X-ray, ECG, and of course the last sentinel of the evaluation, of course, is an echocardiography. So certain questions are very easy to answer. If you have a symptomatic murmur, you have to do an echocardiography. The only question is, what do you do in an asymptomatic murmur? So asymptomatic murmur, then the clinician, both the pediatrician as well as the pediatric cardiologist, has to look at the likelihood of a structural pathology in a asymptomatic. For example, if you have an abnormal heart rate, very low heart rate, very fast heart rate, an abnormal pulses like a high volume pulse or a pulse discrepancy, an abnormal precordium like a cardiomegaly or a thrill, naturally it has to have a structural abnormality. If you have an abnormal S2, if you have a presence of an S4 or a click or a snap, definitely that person has an abnormality. If you have murmur in the right upper sternal border, left lower sternal border, apex, and unusual location, very likely that you are dealing with the abnormal heart. And of course, if in the systolic murmur, early systolic, pan-systolic, late systolic can be invariably an abnormality. All diastolic murmurs are essentially abnormal. Majority of the continuous murmurs are abnormal. To and fro murmurs are invariably abnormal. So you can have an assessment of this. For example, here, the red ones, the early, the late, and the pan will be abnormal. And here in the diastolic, you have an early, mid, late. All diastolic murmurs are usually abnormal. So these tools are available, and X-ray and ECG. The question is, you look at the heart size, the enlargement, but the question always is that how useful is chest X-ray in evaluating a cardiac murmur, especially asymptomatic murmur. Very low yield is there for a chest X-ray. ECG also is very important. It can have a relative important role in an asymptomatic murmur, but it is more important in a symptomatic murmur, especially when the child is relatively blue in making a diagnosis. Now, what we have seen is that among the regular residents, the cardiology residents, the consultants, both old and young, the clinical skills are dropping. Some of the older people may have a dropping of their hearing capability also, which is acceptable to some extent. But echocardiography, also the role is increasing. So there is a question of what to do. You have to do it selectively or what to do. One answer is that all neonatal murmurs, of course, have to have an undergo an echocardiography. We will come to that later. And if you feel that this particular murmur is a potentially pathological murmur, you have to do an echo. The third question is a vexing question, both for a pediatrician as for a cardiologist, and for me is, should all murmurs be evaluated by echocardiography? Newborn, there is hardly any doubt because the prevalence is high. Murmur in the newborn is invariably, almost invariably organic and need not be critical. And you have many of them are very benign condition, but still you have to make a diagnosis and always look for cyanosis, heart failure, femorals, because 2/6 murmur with the absent femoral would be coarctation of aorta, and look at use a good stethoscope. And another thing very importantly is that neonate with a critical heart disease may not have a murmur, whereas a neonate with a 2/6 murmur may not have critical congenital heart disease. For example, you have critical congenital heart disease like PGA, HLHS, coarctation, pulmonary atresia, and even intrauterine myocarditis will have hardly any murmur. And in an infant also, sometimes the lack of the murmur will have some significant heart disease like a coarctation, ASD, a left to right with an Eisenmenger, Al-Kappa. Some of them, the murmurs are not at all important. In cyanotic heart disease also, you have TGA, pulmonary atresia. As I mentioned before, you can have a significant problem without a murmur. Now, loud murmurs invariably, especially in the newborn, have to be evaluated by echocardiography because it's rare. Another practical problem for both an obstetrician as a pediatrician, especially those people look after the newborn babies, is a delayed presentation of a significant VSD or a PDA or a large ASD, even AVSD by around 6 weeks when they come for an immunization, and there will be questions asked whether, how did you miss this diagnosis? So you have to be very, very careful. So asymptomatic murmur, to decide on structural heart disease or innocent murmur, you probably need an echocardiography with some, of course. Why echo? Why should we do an echo? One is, of course, parental anxiety has to be alleviated. Physician also will have a significant anxiety and also naturally to pick up a significant congenital heart disease. There was a major study in the West of almost 200 patients, asymptomatic murmur from 6 weeks to 12 years. And they are evaluated, and almost half of them had some abnormality, included important conditions like a VSD or a ASD or mitral valve. Another very interesting study came from US by McGrindle. He studied 222 patients, including, and all the evaluation was done by pediatric cardiologists. Both the examination, ECG, echo, everything was done by first evaluation, and they found 1/3 as structural heart disease. Sensitivity, clinical sensitivity with the pediatric cardiologist is 92%. So which means that you can have a lower specific sensitivity with the pediatricians or even younger residents. But what he said was that if one of these key signs are there, what we call as a flag, what is it? Red flag, have a good loud murmur, left upper sternal border, harsh murmur, pansystolic murmur, associated click or an abnormal S2, the high likelihood that it is going to be pathological on echocardiography. And so much so he mentioned that if the referring clinicians were reliably able to recognize the 6 signs, referral can be reduced by 50%. It's a very tantalizing statement for both for pediatric cardiologists as well as the pediatricians. There's another study on the cost effectiveness, a pure economic study, which showed that even if you have with echo consultant, etc., you can have 100% efficacy in picking up a congenital heart disease, but it is very, very expensive in United States of America. And anxiety can be of 2 types, parental anxiety and physician anxiety. And there is another original article showing impact of echocardiography on parental anxiety with children with innocent murmurs. The reduction in anxiety level to a dramatic level, statistically significant, both in low anxiety patients and parents and high anxiety parents. There were reduction in anxiety. So again, I am coming back, the pathological murmurs, I think they do warrant an echocardiography, these things which we already mentioned. So the question is basically, this would be a safe way of being politically correct. That is, you do a clinical examination thoroughly, X-ray, ECG, and if you feel high probability of a structural heart disease, go for an echo. If you feel a low probability, like Kunju was saying about EEG, you probably no need to go for an echocardiography. But this is again the tricky area. So the pattern, where have we reached now is that first is the pattern of referral and the selective referral for echo is needed or not. Newborn, definitely an early elective referral. Infants would be an elective referral. Children, of course, probably you could wait and see. Where symptomatic referral is definitely, it has to be either elective or as soon as possible. Now, this is another very interesting study. I somehow don't get the original reference, but I think it's a very important, which I have read through. That is, they have done a study on clinical examination, decided that this particular child has an innocent murmur and this particular child has a pathological murmur, took an ECG. But there was no change in diagnosis. Later, they did an echo on this patient, it changed. Some of the so-called pathological murmur became innocent. Some of the so-called innocent murmurs became pathological. So this, I think, probably is one major study which I use for my support of a possible universal echocardiography. And there are many other reasons also. Finally, the question is to do echo or not in a asymptomatic children who do not have significant clinical pointers to pathology. So the answer would be yes or no. You have S is virtually rules out a structural heart disease, non-invasive, quick decision, avoids unpleasant surprises, which I have experienced, and completely allays parental anxiety. On the other side, you have a cost factor benefit ratio, over-diagnosis in certain, and offers new dilemmas. For example, majority of the newborn babies in KIMS nowadays, CC or Dr. Shobha used to refer almost all babies to me when I was a consultant in SAD. Majority of them had a PFO. So if you tell that your baby has a 4 millimeter, you will cause trouble to the parent. So it is a tricky area. Some children are referred as a trivial MEP, and you are also prompted to do a trivial AVP. It's very difficult because it may be normal. And Doppler TR, Doppler PR, and even Doppler MR in an adolescent can be absolutely normal. Another thing is, yesterday we had a baby who had a murmur. He had a potent foramen ovale. There was a closing PDA because the child was only 3-day-old baby. There was a real tiny muscular VSD, mid-muscular VSD. So you can always sell this disease like your baby has a hole in the heart, 3 holes in the heart, at the atrial level, at the ventricular level, and the great vessel level. But don't do that. You had to sell health. As Dr. Taragan, who is one of my mentors, told me, always try to sell health. So you can tell them what it is. But the other side is that these are all my experiences. You have a newborn pink 2/6 continuous murmur. What will you think of? You'll think of a PDA. But saturation is also 94-95. But echo showed a single ventricle with pulmonary atresia with a small PDA. So PDA was one which was supporting the circulation. Now, we had another child who is pink 1 systolic murmur at the base. We thought was basically normal split, I thought, and it turned out to be a moderate OCM second AHD. Newborn baby, again pink saturation 95%, 2/6 murmur turned out to be a pink tetralogy of fallow. Infant with pink apical 2/6 murmur turned out to have an LTGA with the left AV valve regurgitation. And recently we had one child 2/6 pansystolic murmur in a child, and that child was actually being followed up for some time as a rheumatic MR, and it turned out to be an ALCAP operated, and he is doing very well. So this would again underline the need and the scope for echocardiography in the current scenario. And this was in 1842. Basically, this comment was basically on auscultation. That is, men are often deceived by their ears as their eyes and may hear ghosts as well as see them. Ears must be educated and well practiced here. or it is not a trustworthy witness. So we have to accept our limitation. All of us, young, old, consultants, non-consultants, should accept some failing on our part in clinical acumen. The times have changed. And secondly, I think this is another one, 1996, 150 years after Latham said about murmur evaluation. Tavel, actually, he is an authority on cardiac auscultation, and he was lamenting the impending, what you call as a funeral of auscultation. That's a glorious past, but does it have a future? So between this, I think we have to know the technology has really it strikes back, like in Star Wars, as Abhiram would say, because we are all lovers of Star Wars movies. And this is an opportunity for us to make a quick diagnosis. So I thought, or I think, should an echo be done in all murmurs? I would use a very carefully worded answer, probably yes. Because for a clinician, not only in cardiology, not only in murmur, the best answer would be probably, because we are not 100% sure. And it virtually rules out a structural heart disease, is non-invasive, quick decision, avoids unpleasant surprises, very important, and not very expensive in Indian context, unlike in the Western context where the cost may be around $250, which you can convert if you have good in arithmetic, would be a big sum. And I will be, of course, glad to answer any queries put through this electronic media, because I have, for Praveen, I would not have taken up this code as like salary challenge, the Zoom challenge. Thank you, Praveen, for this.
Thank you, sir. Since you brought up
time, but probably I borrowed Muhammad Kunju's time.
It's since you brought up the Star Wars, I'll ask a question that anybody, the participant, can answer. What is the relationship between Zulfiker sir and a famous sword?
Which sword?
Famous sword.
Zulfiker is a sword.
Yeah.
Used by Solomon, King Solomon, who is also called Sulaiman.
Imam Ali, sir. Sword
Imam
of Imam Ali.
Imam Ali.
Imam Ali.
Hazrat Imam Ali. Okay.
Yeah, Hazrat Imam Ali. Yes.
Okay. But there was another Zulfiker, which is a sword of Sulaiman. Sulaiman is in biblical terms Solomon.
Solomon. Okay. Okay.
You remember the King Sheba?
Yeah.
3.5 years from Ethiopia to meet and marry Solomon.
Yes.
Anyway.
I think Shankar sir is already ready. So then we will take any questions which is there after this thing.
Yeah, thank you. I am looking forward to this COVID-19. I mean, at least in diagnostics.
Yes. Now we will have an immortal from Meluha to take us through the current topic, which is COVID-19 and the role of molecular diagnosis. Sankar sir needs no introduction. He is the additional professor of pediatrics and pediatric geneticist, SUT Hospital, and he was the past president of IAP Thiruvananthapuram branch. And he is one of our most strongest support pillars for IAP Thiruvananthapuram branch. I think there is a hand. Dr. Shahana will take the questions afterwards. I think if Shankar sir is ready, he can. I think you can continue, sir.
Okay. Good evening, Abhiram. I'm hearing?
Yes, sir.
Okay. Good evening. At the outset, I thank the President IAP Thiruvananthapuram, Bennett, Priya Secretary, Praveen, Abhiram, Anju, everybody to give me the opportunity to talk on this topic on role of RT PCR or molecular diagnosis in diagnosis of COVID-19 infection. So it's very difficult to talk after my teachers, Kunju sir and Zulfi sir, but I will try to do my best to tell in next 20 minutes or 15 to 20 minutes what's the role of laboratory diagnosis, especially molecular diagnosis in COVID-19 infection. As all of you are aware, COVID-19 is an infectious disease, a pandemic viral disease by coronavirus. Just an introduction slide to know about what is a coronavirus, because this is very important to understand of the diagnosis of coronavirus. It is a spherical or pleomorphic virus. It's a single-stranded RNA virus, and the envelope bears club-shaped glycoprotein projections, which is actually important as a protein product as well as the antibody projection in the body. And usually the coronavirus is causing the human simple rhinitis, 4 or 5 types are there. But some of the genetical variant of coronaviruses can produce severe pneumonias like MERS, SARS, which we know epidemics has occurred earlier. So in 2019, a coronavirus-related severe pneumonia occurred in China, and later it has been identified that it is a genetic variant of SARS. So that is why the terminology has been changed from normal coronavirus 2019 to SARS coronavirus 2. So as like any disease, already we have discussed about the diagnostic stewardship of echo in murmur or EEG in a seizure. Similarly, in infectious disease, this diagnostic stewardship are very, very important for the etiological definitive diagnosis, especially in a condition like pandemic, where the control of infection is very, very important. So a clinician or a public health person, anybody, has a lot of questions. When to test, whom to test, what to test, how often to test, or what to do with these test results. All these questions has to be answered for the proper management of the patient. So altogether, you should have a diagnostic stewardship for utilizing various types of diagnostic test for this COVID-19 infection. For that, you should know about the principle behind the test. For example, RT PCR. So what is this test? What is the basic principle? What are the limitations? What is the advantage, etc. you should know. And how to interpret the results. What are the important points you should consider when you are considering the results, etc. And applicability in local, regional, and national level is very, very important. Because ideally, if you do the test in everybody, it's a classical ideal situation, because you are testing the 100% of the population with the RT PCR and saying that whoever is having the infection, whoever has to be quarantined. Along with that, you are doing the antibody test, which will help you to say that which all people are immune. It's a best scenario, which is absolutely not applicable because of various logistic concerns. So applicability in local, regional, national level also has to be considered. But WHO has told test, 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 test. So you have to do maximum test to identify the patients. And the test recommended was RT PCR. Why? I will come to that next few slides. But if you come to the Indian scenario, compared to the international scenario, testing is not that much high compared to international scenario. But we are doing reasonably good, but not like an international scenario. Kerala scenario is also, if you consider the test per lakhs population, we are high, but total number of tests is definitely less than the states like Maharashtra, Tamil Nadu, or Andhra Pradesh, etc. We are having so many centers approved by ICMR. Maximum centers, I think, from Kerala only. We are, in general, we can say average 1 center approved by ICMR in every district. And testing strategy is we cannot say the major problem, major limitations now, but we are not having much test at present. We have to include so many new indications also, then only we will be able to do more number of tests. So availability is a problem. Centers for molecular diagnosis, already I told there are, now we are having them available. And availability kits is also a problem because kits is not freely available. It is actually coming through ICMR. So there are some limitations are there. Cost is also a big problem because an RT PCR kits is costing 2,000 per test. It is a bare minimum test I call. If you are doing it in the private sector with all other cost of the salary and etc., it will be definitely more than that. Even just for consumables and basic things, somewhere around 2,500, 3,000 will be the cost for RT PCR test. Testing strategy as per ICMR recommendation. This is the standard testing strategy recommended by ICMR. All symptomatic individuals who have undertaken international travel, this 14 days has been given from first itself, but we can include any international travel recently, and all symptomatic contacts of laboratory confirmed cases, all symptomatic healthcare workers, and all patients with SARI and asymptomatic direct or high-risk contacts of a confirmed case should be tested once between 5th and 14 days. In hotspot and cluster, more number of tests, and all symptomatic ILA, that is influenza-like illnesses. So these two type of groups, that is the 5th indication and 7th indication, in any case of SARI or influenza-like illnesses, if you have got a strong suspicion, you can do, which we are not doing it regularly in everywhere, which we included more number of cases in this category. Our testing number will definitely increase, but due to some logistic reasons, we are not doing regularly, but we are doing the surveillance technique we are doing in some of the centers. Now we will come to the what are the different tests are available for COVID-19 infection. The most important test and accepted test is the nucleic acid amplification test. As already I told you, RNA is the nucleic acid in the COVID coronavirus. So you should be able to amplify by a technique called reverse transcriptase PCR, which can be a conventional and real time, which will take little around 6 to 8 hours. But 6 to 8 hours is the laboratory time. But practically for a clinician, it may be 24 hours or 48 hours if the lab is not in your place. You have to transport the sample. Sometimes it will take 2 days, 3 days, 4 days. But as in Kerala situation, we are having almost, for example, if you take Trivandrum, we are having 2-3 labs in Trivandrum itself. So it is not a major issue. Transport is not a major issue, but still it will take around 24 hours to get the result. 6 to 8 hours turnaround time is a laboratory time. And rapid RT PCR platforms, which will give the results by around 2 hours or 2.5 hours. I will come to that, 1 or 2 examples of that. And lab is a new technique where it is a point of care testing, where there is no big machine is required. You can go to the field and do the test. These are the various nucleic acid amplification tests, which we are going to discuss in detail in next few slides, because this is the most accepted and most important test for the diagnosis of COVID-19 infection. Viral culture is best test, but it is not at all recommended because of biosafety problem, because it is recommended only in some special labs where biosafety 4 facilities are there. Because of the contamination and spreading of infection, in India, viral culture is accepted to do only in the National Institute of Virology, Pune, in special situation only. Routinely, no diagnostic lab is recommended for viral culture. And immunodiagnosis or serological test, where antigen detection can be done or antibody detection can be done in any viral disease. But as per the COVID-19 infection, antigen kits or antigen test is not really available. I will come to that in last slide. And antibody detection that we are hearing for in the last few days, some rapid test kit has come because of the locality, it has been discarded, etc. So this antibody detection is having so many limitations, which I will come to that. So this is my main presentation. Which is the specimen we should use? Ideally, the specimen should have a viral mRNA, viral RNA should be there. The ideal secretion is upper respiratory specimens like nasopharyngeal or oropharyngeal swabs for wash in ambulatory patients. But if the patient is having significant lower respiratory tract infections, in adult patients, you can use sputum if produced, or endotracheal aspirate or bronchoalveolar lavage in patients with the more severe respiratory disease. But make sure that these procedures like bronchoalveolar lavage or a wash, etc., have aerosolization will be there. So there is more chance of spread of infection, adhere strictly to infection prevention and control procedures. So standard, usually we will take nasopharyngeal and oropharyngeal swabs. Additional specimens like blood or stools can be taken in special situations, because coronavirus is secreted in the stool, especially in pediatric patients. Blood during viremia, you can isolate virus from the blood also, but it is not routinely recommended. In special situations, blood stool can also be taken, and autopsy material in deceased individuals. In all these situations, we will do RT PCR. The specimen for virus detection should reach the laboratory as soon as possible after collection. But if there is not much delay, specimens can be transported in 2 to 8 degrees centigrade. We are transporting actually in the what we can say, in the ice pack, triple layer packing and proper labeling and ice pack. And you can just a few hours or few minutes, minutes or hours, you can store in the simple fridge itself. But if there is delay for more than 2 days, and specimen can be stored as -20 and -70 degrees centigrade, which can be do it later also, but it is not applicable to us because we are having enough facility to the lab in most of our place. Transport of samples within the country should comply with the national regulation. If you are sending outside, which is not applicable now, which is not required now, should be international regulations also has to be written. And swabs are placed into a liquid to release virus and viral RNA from the swabs into solution. And RNA will be extracted from the solution. And most important thing is, this area is little bit tricky because it is the chance of contamination to other people is there. So a PPE kit and all safety precautions has to be taken, and it should be done in a biosafety cabinet with a negative pressure so that it will not come into the person who is doing it. And the lab should have a BSL-2 or above facility should be there. That is a standardization of the lab where there is a significant facility to prevent the infection. and viral RNA is extracted from that solution, and subsequently it is amplified by PCR technique. So what is PCR? I think most of the people knows PCR is a polymerase chain reaction where the gene of interest will be amplified. Please here, gene of interest. It can be human DNA gene where the genetic diseases will be diagnosed. Here actually we are interested in the viral gene. This viral gene of interest has to be amplified by a technique called polymerase chain reaction, which is a series of denaturation, annealing, and extension. But here, this PCR is basically done in a DNA. Here, virus is an RNA virus. This RNA virus or RNA genome first has to be changed to a double-stranded DNA, which has been shown here, which is by the reverse transcriptase. That is the name RT PCR, reverse transcriptase. When it is a double-stranded DNA, that is cDNA will be changed into a two-stranded DNA. Then it will be denatured. Area of interest will be, primers will be attached, and area of interest will be amplified. And whenever there is an amplification, particular gene is there, the gene will be amplified. The probe will be released from that. This probe will be showing here it's a color. So in the RT-PCR, immediately you will get the puncture or color, which saying that the positive result is there. So we should know the genome of the SARS coronavirus, then only we can do the specific primers. There are so many genes in SARS coronavirus like spikes gene, S gene, or N gene, or E gene. That is a nucleocapsid gene, envelope gene, S gene, as well as some of the important gene for polyprotein, etc. So there are so many protocols are there where the primers are designated specifically for spike gene or specifically for E gene or N gene. But in a standard RT-PCR, minimum 2 or 3 genes will be identified to make sure that we are not going in a wrong direction. That is, if you are doing only one gene, sensitivity of the test will be less. So minimum in RT-PCR, standard conventional RT-PCR, we used to do 2 or 3 genes. Minimum 2 genes will be checked. Depending upon the different protocols, different lab protocols, there will be variations will be there. Now coming to the detection rates of this RT-PCR, because whenever a clinician is addressed with some test, he wants to know what is sensitivity, what is specificity, positive predictive value, what is negative predictive value, these things are there. But as far as these tests are concerned, we don't have a large series to tell that what is sensitivity of RT-PCR, what is specificity, what is sensitivity of rapid testing, etc. Because it is a new virus, test has been recently come. So we don't know the perfect thing, only we are having small series are available. Detection rates in each sample type vary from patient to patient and may change over the course of the individual's patient illness. That if you take early or late and from patient to patient, depending on various things, the detection rate may vary. But in general, RNA RT-PCR, in first 1 to 7 days, detection rate is somewhere around 65 to 70%. Still, it is not 100%. That's the most important thing. People feel that RT-PCR, if it is positive, it is coronavirus. If it is negative, it is not at all. It's not like that, because sensitivity is somewhere around 65 to 70%, even in 1 to 7 days, because there are so many false positive as well as false negative. We will take false negative first because a number of factors could lead to negative results in an infected individual, because patient will be infected but test may be negative because poor quality of the specimen. That I think everybody can easily understand. If you are taking nasopharyngeal swab or oropharyngeal swabs, you are taking only very small few specimens where there is not much RNAs are there, you will not get the results. And the specimen was collected late or very early, because after 7 days, shedding of the virus may be very minimal, so you may get negative. Similarly, early asymptomatic, that is why when people are coming from the outside countries, if totally asymptomatic, we are not routinely doing it because utility of the test is not very high. So we will tell them to be in quarantine. If you develop the fever, you come back, we will do the test. You can do it if there are enough kit is there, enough facilities there, you can do it, but positivity rate will be minimal in totally non-symptom patients. The specimen was not handled and shipped properly. So that means if there is a cold chain has not maintained, etc., it may be negative also. And finally, technical reasons inherent to the test like virus mutation or PCR inhibition. That is another problem, because some substances, if there is a sample of blood has been contaminated, hemolyzed sample is there, then you will have a PCR inhibition may be there. So false negative is a major problem where sensitivity has been reduced to around 60-70%. False positive is not very common, but it can occur due to contamination of the sample during collection, transport, or laboratory procedure. That means if the person who is doing this test is having some coronavirus infection, it can be transmitted. Or if there few samples are there, positive samples are there, sample to sample contamination also will give a positive results. Another major problem is persistence of viral RNA, because now we are seeing that 32nd day, 40 days, we are getting a viral RNA positivity. How will you interpret it? Because patient is not having any symptoms, what will you do? It has been shown that viral RNA can persist for a long time in body fluids, but person may not be infectious. It has been shown in other viral epidemics like SARS, MERS, as well as in Zika virus. In Zika virus, it may be positive up to 3 months, 4 months positivity has been proven. And in coronavirus itself, it has been shown, a Chinese study, it has been shown that viral RNA has become negative in 32nd day after the test positivity. And after symptoms in another lower category, it's 55th day. So but it will be less, number of patients will be less, but it can get positive. Because that means if there is a RT PCR positivity in 32nd day or 40 day, that doesn't mean that patient is highly infectious. Very unlikely to be infectious, because transmission of infection will be very high in first 10 days. Ideally, if we have to prove it, we have to do viral culture or subgenomic mRNA studies, that is expression studies, which is not possible in a routine setup. But in a public health scenario, if patient is positive, we have to do repeated tests till become negative, and only at this juncture, we will be able to discharge him only after negative results. That is the state protocol, but that is possible. That doesn't mean that he will be highly infectious. Now, finally coming to a rapid testing, because already I told you this RT PCR is the best test, that is the most recommended test and best test now available for coronavirus. But always, already I told you, in a state like Maharashtra, where there is facilities only available in Bombay and Pune, in a remote setting, it will take 3 or 4 days to get the positive results. Definitely, there is more chance of transmission of infection to other people. If you identify early reporting, diagnose early, interfere early, naturally the spread can be definitely controlled. So rapid test is very, very important. So there is a concept of rapid PCR already I told you, because it's conventional real-time RT PCR will take 6 to 8 hours or 24 hours for get the result. So there is a TrueNat TM beta COVID test, whereas a small machine is there, where they will test only one gene. So sensitivity will be a little bit less, but you can do it because cost is less, fast results. 2 to 3 hours you will get the result. But ICMR recommended this as only a screening test. All positive samples need to be reconfirmed by a separate confirmation assay. Genexpert is another platform where already we are doing tuberculosis RNA testing, but this is a confirmatory test. But now ICMR is recommended this only for samples in emergency nature, like symptomatic health worker, patients who need surgery, or COVID suspect deaths, because we will get the result within 45 minutes. But here problem is it is costlier. Already I told you RT PCR costing somewhere around 3,000. Genexpert is costing somewhere around 7,000. So now ICMR is recommended only in some special situation you can do Genexpert, and Genexpert has been started in Trivandrum, Calicut, and Ernakulam, that is Cochin. So we have started Genexpert already in last 2-3 days. Few samples already in Trivandrum Medical College. We are doing Genexpert in some special situations. LAMP is a new technology. This is already you would have been read in the newspapers. That is the new technology Srijitra has developed. That is loop mediated isothermal amplification. Is a novel nucleic acid, robust, specific, efficiency, rapid under isothermal condition. That means here doesn't require a robust machine. You say you can take a small machine like our card swiping machine, where you can go to the field and do the testing, and rest results you will get within 1 hour or 1.5 hours, because I am not going to the technology. And this is a new technology identified in 2014, little bit different from PCR. Technology itself is different, but not well standardized technique, not much maximally used in COVID or any other viral infection, but it has been well utilized in some of the veterinary viral disease spread. So there are so many papers throughout the world, and N-gene protocol has been recently identified by the Srijitra Medical Center, but they have applied for the ICMR for the other things, but so far ICMR has not given any permission to do the test in a large scale, but it may come within few days. Pooled sample testing in a research limited setting, it is very good option, because you are having so many patients. If you are able to do only 50 samples a day, in pooled specimen, you can do 50 into 5. 2 to 5 individuals can be pooled. That means 5 individuals will be included in one sample. Another second 5 individuals will be in one sample. So 50 into 5, you can do around 250 samples together you can do. And wherever samples are positive, these samples will be repeated individually to look for test positivity. And entire pool sample is negative. All these individuals will be considered as negative. So it's actually resource limited setting. More number of RT PCR can be done. Only in India, Uttar Pradesh has given this request for this pooled sample testing, and they have been permitted. I think they are doing this pooled sample. No other state has started it, but in resource limited testing, we can do it. Now coming to the immunodiagnostic, only 2-3 slides are there. Here, antibody testing against coronavirus, that is human antibody has been formed against coronavirus. This antibody develops by around 7 to 11 days, but accuracy and reliability of the testing has not been well studied because these are all new studies. There are so many test kits are available, around 24 or 25 kits are already approved by FDA and European Union. But here certain limitations are there, like past infections from SARS coronavirus is a problem because already I told you 95% genetic similarity between previous SARS. So if somebody has got infection with SARS, they may get developed antibody, which is IgG, which may give cross positivity for this. And cross reaction with other coronavirus is another problem. And antibody to which antigen is better, because there is a spike antigen, there is a N antigen, M antigen, so many antigens are there, which is better. But most of the protocol says antibody to spike antigen is the best thing because which is having a highest positivity, which is important for the uptake. So most of the protocols, most of the kits is having the spike antigen. Serological testing is not usually used for in the acute care setting because already I told you it will become positive only after 7 to 11 days. But it is used for serological surveillance at the local, regional, state or national level. We want to know in some taluka or Koladupura or somewhere we are suspecting community spread. You do so many people, you do positivity to say that how many positive results are there, which shows that how many asymptomatic infection has been spread in the community. And another thing is identification of those who have already had the virus and thus may immune, so that these people can be sent to the area where again work for the hospital, etc. Because the health workers, 50% are already positive, you can send them to work again. But this is not the recommended protocol because we don't know whether these antibodies are lifelong and they are neutralizing antibodies and they will protect you. There is no confirmatory. For that, you have to do some special tests, but can be used for this. And serological testing may also be used to identify individuals for therapeutic or prophylactic neutralizing antibodies. Because plasmapheresis, we want to identify the patients who are having antibodies because this protocol will be started if you have got a moderate to severe patients because already applied to ICMR for this phase 2 trial. So to identification of the people, we can do the serological testing for contact tracing and in to identify the PCR assay. Already do 70% PCR assay. We will do 100% PCR in some people, and same people we will do the immunodiagnostic test to say that what is the sensitivity of the PCR and identification of the viral infection. That can also be done with this. And diagnostically test the viral negative individuals can also be identified by this testing. So there is some protocol is there. Sir, if you symptomatic ILI, home quarantine for 14 days and you do a rapid antibody test. If it is positive, it is a COVID-19. And if it is negative, if patient is still sick, you do an RT PCR. If it is positive again, it is COVID-19. Both serology is negative, RT PCR is negative, it is a non-COVID-19 ILA or susceptible. Whereas similarly, if antibody testing positive after 10 days, then this is a probable COVID-19. So this is a protocol which can be used by a clinician, but at present it is not recommended. At present, in all acute care setting, RT PCR has to be done for the diagnosis of COVID-19. This is the same slide which I told that total antibody will be 100% by around 15 days. But early if you do, in 1 to 7 days, it's only 38%. So in the early stage of the illness, definitely antibody is not a better test. Later stage, it is a good test to diagnose. Antigen detection, if a good kit come, rapid test come, it is excellent. You can go to the point of care, you can go to the field, do the test, identify the patient, quarantine it. But at present, there is no a good antigen detection serological test. So WHO does not currently recommend the use of antigen detecting rapid diagnostic test for patient care, although research into their performance and potential diagnostic utility is highly encouraged. If you go to the net in European Union as well as in FDA, there are so many kits has been approved which can be used in the some community to identify the seropositivity. So coming to the take-home message, nucleic acid amplification test by RT PCR is the best test available now for the diagnosis in acute setting. So in acute setting, this test has to be promoted. This has to be done. But which patient you will test? Ideally, all patients, but it may not be possible because of logistic reasons. So state protocol has to be followed to identify which person we will be testing. Immunodiagnostics testing antibody against coronavirus is helpful in a community testing to identify the seroprevalence, but in acute care setting, limited role. A point of care, rapid, robust, and sensitive test is a need of the hour, which will help to control the epidemic, which there are so many things are there is going to come. I think next few days, all these things will come. Thank you very much for patient listening. Try to answer the question. Thank you.
Thank you, sir. I think Saji can ask the first question. Saji had some questions to ask. He has put it in the chat. He can ask directly. Zulfiker.
Yes.
Okay, wait.
Abhiram, you can ask the questions.
Saji,
Read
Saji
out.
is there?
Better to read out the questions.
Amit
Abhiram,
can ask the
better
question.
you read out the questions.
Abhiram
Otherwise, it will be a
chat ഇട്ടിട്ടുണ്ട് ആ ക്വസ്റ്റ്യൻസ്
വായിച്ചാ മതി.
Okay.
Otherwise, there will be a lot of commotion. Abhiram can read out the questions.
Yeah, that is good. Abhiram.
Okay, right. Then the first question will be, should all ILA be referred for testing? Sankar sir?
Yes.
Should all ILI be referred for testing?
Okay. That's I told. Actually, if it's a community spread has already occurred, then all ILA has to be tested. But logistically, there are two issues are there. One, we should have a sufficient facility to isolate them till positive comes. So now we are decided to do only for SARI, that is severe acute respiratory infections only, we will do the testing. Because as far as our understanding, even in adult, we are not having that much community spread. So now we are planning to do only SARI. But as I told, the indication is basically logistic reasons. Ideally, in a community spread is there, we have to do in all ILI. But at present, I think we can just little bit wait and we can do in a severe SARI, severe violent pneumonia case where lymphopenia is there, bilateral infiltrates are there, no other diagnosis is there. This type of patient can be selected and do. Then only we can go to a simple ILI. I think like that, because that's more of a state protocol and logistic reasons rather than a pure technical reasons.
Okay, I think that answers the question. Next question is COVID-19. Any difference in genome of virus in India compared to China or West?
Okay. So actually, this virus, that slide I have not put regarding the sequencing to identify from where the virus came, what is the gene sequences, how the sequencing has to be done. Sequencing in India, there are 2-3 centers are doing, NIV is doing, IGCY doing, and we are doing our Indian positive cases. Some studies are there, and IGIB one study is there. NAV is also doing at the government interest. But as far as we know, we don't have much publication on that. But if you take the China and the end route, basically from China, they have got 3 types of gene strains are there. Actually, most of the Chinese case go into one strain, that is severe variety, another is a milder variety, little bit milder variety. The severe variety has been gone to the US actually. That is same strain they got in the US. And the milder variety, it has got in the other Southeast Asian countries, Singapore, etc., etc. And Europe strain is little bit different. All these having little bit genomic changes, but basically all these things are same. But there is not much reports are there. Few studies shows that there are 3 types of strains in difference in the severity.
Okay, sir. I think
the second question is answered. That is in Indian strain, there are 2 things are there. One is it is less virulent. Less virulent, I mean in China itself, we have got some less virulent strain that is actually spread in all Southeast Asian countries. And another reason I have told is because of the polymorphic variation in some of the immunity in the Southeast Asian population. This virus a little bit milder forms are there in India and other Southeast Asian countries.
Okay, I think Amit's question is also been answered because he has already told who has to be tested. If any further clarification, Amit, please again send a chat. And next question is, how valid is COVID RT PCR in asymptomatic individuals? Does RT PCR come positive with dead COVID pathogens? Shankar sir?
RT PCR come in dead COVID patient.
Yeah, pathogens. If the pathogen is dead.
No, no. Pathogen
No, no. Whose question it is?
How valid is COVID RT PCR in asymptomatic individuals?
Oh, that's I told. That's I told.
Yeah.
Because in an asymptomatic individual, if it is positive, that means virus is there. But whether it is a live virus which is proliferating, which is transmitting to other people, etc., we may not be able to tell. But in some situation, this virus escalation can be there up to 32 days or 35 days or more than that. Okay. So, but at present, since there is no other test available, we want to containment the infection. In public health point of view, whenever there is a positivity, we have to consider them as an infected person and we have to take all quarantine steps. But practically, we know that in asymptomatic individuals, if it is positive, if in first few days only, there is a maximum infectivity is there. But asymptomatic individuals, especially in an immunocompetent individual, and specifically it has been shown in the pediatric age group, a 6-year-old, 7-year-old, he may be positive up to 20 days or 22 days. He doesn't have any problem because he's having good immunity, but he can transmit the infection. So any virus positivity, we have to take it. Otherwise, we have to do the specific test like viral antigen or subgenomic mRNA, which is not available now.
And the other question is also like, you don't need to have a live virus for RT-PCR to come positive, isn't it?
Correct, correct. It doesn't mean that it is a live replicating virus.
Yeah.
Because
so
we are detecting the RNA. We are detecting the RNA.
Yeah. That means the dead COVID pathogens, already virus is dead also, you can have positive test.
Yes, yes, it can be positive.
I think that answers Sri Lakshmi's questions. And Anju Kanmani wants to ask, can we do pooling in nasopharyngeal swab?
Yes, yes, that's a goal. Pooling in any sample we can do. That means we will take from 2 to 5 patients, patient 1, patient 2, patient 3, patient 4, patient 5. All this RNA will be mixed and do the PCR. So if there is 10 slots are there, we can do 10 patients. Instead of that, we can do 50 patients. In a single RT PCR, usually it will be a 48 well or 96 well. So instead of 48 patients, we can do 48 into 5. That much number of patients you can do at a stretch. And whichever tubes it is positive, these patient samples, again, you have to do individually to look for 1 positive, 2 positive, 3 positive. And if it is negative, all 5 will be discarded as negative. So it is a resource limiting step. It is good. In nasopharyngeal swab also we can do, but swab we will not do. Swab we have to take separate. And RNA we have to take separate. When we are doing the PCR mix only, we will mix it up.
And another question is, what is the mechanism of cured patient getting positive again?
That's it all. Okay. Cured patient again get positivity. Okay. Cured patient positivity, nobody knows whether it is a reactivation or a reinfection. But one negative results and then again positive, so many patients you can get it. Because already I told you, when you are doing repeated samples on 8th day or 9th day or 10th day, you are taking sample, there is not much sample things there. There is negativity, is a possibility. False negative, can it come? So that is why we are telling 2 negative samples should be there before discharging. Because 1 negative sensitivity is only 70%. If there is 2 negativity, almost 95% it is cured of infection. So that is why 2 negative samples should be there within 24 hours apart. Another situation is you are having 2 negative, you've gone home after 1 week or 2 weeks, again you are getting positivity. In India, there is not a situation so far we are not got, but there are some reports that in South Korea and some other people who are getting this positivity, but it may be a reinfection or react. That's I told, there is nobody have got a proof that these antibodies are lifelong and it is protective. Because for a protective antibody, it should be a neutralizing antibody. Only one type of antibody, because there are some NEBM paper is there where they have detected the 3 types of antibody, which antibody is high. This neutralizing antibody may not be in high level in some patient. There is a possibility of reinfection in an epidemic situation. Reactivation, nobody knows because viral infection, reactivation, we don't know.
Another question is, in immunocompromised patient with COVID, how RT PCR will be?
Immunocompromised individual?
RT PCR, what will be the result? Will obviously be positive, no?
Obviously, there is no difference. Immunocompromisation will not give any test difference in RT PCR. If there is infection, you will get it. There is more chance of getting infection. It will not alter the RT PCR results.
And if Bala wants to ask, if PCR is positive even after 28 days, is the patient still infective? And should we repeat every 2 days till it becomes negative? I think Sarah.
That's the thing I told. Actually, I actually answered I think, that the persistent virus problem is there. So technically, if you talk in academic session, we can say that less chance to be infective, because we have shown that first 10 days is the maximum infection. If patient is totally asymptomatic, 28 days, very unlikely to be infective. But in a public health setup, we cannot, we are having only handful of cases, 2 or 3 cases. We cannot give that patient to the positive patients to outside. So we have to keep the patient in the hospital till 2 samples become negative. But if there is an epidemic fashion, we are having so many number of patients. There are some papers are there. They have told you don't have to become negative till 28 or 30 days. If patient is symptomatically better, send them home. But at present in Kerala situation or India situation, we cannot send. We have to keep at the hospital and make sure that they are become negative.
Zulfiker sir.
Yes.
There's a trick question to you.
Yes.
From Bennett sir. Did you see that? Does all children with murmur, we should take X-ray and ECG before
I think that's a very, very valid question. Correct. It's a very valid question because, see, we always tell in academic forum that we should not go ahead and do an echo without a basic understanding of an X-ray and ECG. But what happens is that when you are dealing with an asymptomatic murmur, if you are dealing with a genuine symptomatic murmur, it's natural that we should take an X-ray, ECG, and then go to an echo route. Suppose you have an asymptomatic murmur, where the probability of a genuine significant heart disease is relatively less. I think it's enough that you directly send for an echocardiography, because this kind of strategy has been used in the West also. I think it has shown practically 100% yield. But the cost in the West will be much more higher. And because when I was much younger, as Dr. Priya knows, I used to insist on an X-ray and an ECG for but I think I have modified, because Sukumar Adikod പറയുന്നത് പോലെ ഒരു അഭിപ്രായത്തിൽ 30 കൊല്ലം ഒന്നിച്ച് നിന്ന് കഴിഞ്ഞാൽ ഒന്നുകിൽ അയാൾ മണ്ടനാണ്, അല്ലെങ്കിൽ അയാൾ മറ്റുള്ളവരെ മണ്ടനാക്കുകയാണെന്ന് പറയും. അതുകൊണ്ട് I have changed my, but it is applicable to only what you call as asymptomatic murmur. Symptomatic murmur is very important. For example, you can have a supraventricular tachycardia leading to a dilated cardiomyopathy, or you have you can have a dextrocardia with some problem.
Yes, sir. And especially in asymptomatic murmur, we will decrease the risk of extra exposure to the child also.
It's practically difficult to do an ECG sometimes. But see, for example, a child comes with a suspected syncope, and Dr. Mohammed Kunju feels that it is absolutely non-neurological. Then I think we may have to take an ECG because of the syndrome and various other things.
ECG is okay, sir. About X-ray, because there is a radiation risk also.
Exposure is correct. Exactly. But Abhiram, you must realize that there is an increasing tendency of both our colleagues or ourselves, radiologists, make CT imaging, because it's very convenient and less time consuming rather than taking an MRI. But that also should be borne in mind.
Yes, sir.
Thank you, sir.
And I think another question from Murali Raj to Shankar, sir. What's the best sample to be taken for newborns? Can a gastric aspirate send?
Actually, this first part of the question, I think still nasopharyngeal swab or nasal swab or the oral swab will be better. The second part of the question, even actually, I don't know. I have not gone to any literature seeing that gastric aspirate can be sent. I have not seen it. I have to check it up. But in pediatric age group, in the newborns, as well as 4 months or 5 months, usually these children will have diarrhea also. So the stool samples, already I told you, one special situation they have told children coming with the diarrhea, along with the respiratory infection, you can send the stool sample also. Usually it will be positive. So stool sample can be sent. Gastric aspirate instead of the, because they will have routine aspiration, whether gastric aspirin, I have not got any reference with that. I have to check it up. I will check and inform Murali, because I don't know about the gastric aspirate, but usually nasal swab can be taken. And
Dr. Priya wants to know how often we repeat the sample in positive patients.
Okay. As per the guidelines, in positive patients, in every 48 to 72 hours, we will repeat the swab. 48 to 72 hours. Every alternate day, or 2 days or 3 days, we will do the repeat sample till they become 2 samples negative.
How? Okay, that then can expert COVID detect dead virus in a patient who has already died?
Yes, it's possible because already I told you, because the expert COVID is nothing. It's only the cartridge and other machine is different. It is a simple RT PCR only. Only thing is they will have a closed system. They will have their own cartridges, their cartridge based test. So there is no need for RNA extraction. Directly blood can be loaded there, and one or two genes, depending upon the protocol, they will identify. And there also, if RNA is there, it can be live or dead. It can be identified. So in that patient also, if virus is there, can be identified just like any RT PCR.
And Balachandra has again asked, I think that has already been discussed. What are the reasons for
Correct. That basically based on they have told we can't do the immunity difference, because if there is CD, they have a very good cell mediated immunity, good NK cell activity. That is why they told immunocompetent children is the maximum largest population where this positivity is very, very high. That means even after few days, they will become positive. So immunocompetent individual, it is more possible. That is one of some of the association factors they have identified, but it definitely what is the reason, nobody knows.
Even in measles, I have done some research after this. It is up to 3 months, it can be positive, but it is not infective.
Correct. That is a Zika virus they have done up to 5 months. 5 months it was positive.
Narayan sir, any comments? Narayan sir is still there?
Oh, no.
Yeah, that I think Manjusha has been already answered, just now answered.
നാരായണൻ സാറിന് അൺമ്യൂട്ട് ചെയ്താലേ സംസാരിക്കാൻ പറ്റുള്ളൂ അഭിരാം.
സാറിന് അൺമ്യൂട്ട് ചെയ്യാൻ പറ്റും, പേഴ്സണലി അൺമ്യൂട്ട് ചെയ്യാൻ പറ്റും. ഞാൻ ആ ഓപ്ഷൻ ഇട്ടേക്കുന്നത്.
ഓക്കെ.
നാരായണൻ സാർ ശ്രദ്ധിക്കുന്നില്ലായിരിക്കും. സാർ ഉണ്ടെങ്കിലും സാറിന്റെ ശ്രദ്ധ ഇവിടെ ഇല്ല. ബാല want to say anything?
No, ബാല സംസാരിക്കും. Hello, Dr. Bala.
Again, once again, thank you, Bennett sir and Priya for organizing this very important meeting. We have got one of the best speakers in our country, and I'm sure everybody must have benefited. Shankar, I want to ask one question again.
Some lag is there. Balയുടെ കണക്ഷൻ എന്താ പ്രശ്നം? റേഞ്ച് പോയി.
ഹലോ. അഭിരാം. അഭിരാം.
പറഞ്ഞു സർ.
കേൾക്കാം സാറേ.
Yeah, the session was very good. It is very informative. There is plenty of background noise here. That's why I didn't answer. Congratulations, IAP Thiruvananthapuram. Thank you.
Bala wants to say anything. There are some disturbance in between.
Hello, കേൾക്കാം അഭിരാം?
കേൾക്കാം.
കേൾക്കാം, പറഞ്ഞു.
എനിക്ക് once again thanks. ശങ്കറിന്റെ ഒരു ക്വസ്റ്റ്യൻ കൂടെ ചോദിക്കാറുണ്ട്. ശങ്കർ,
പറഞ്ഞോ. കേൾക്കാം.
After 20 days,
അത് ചാറ്റിൽ ഇട്ടിട്ടുണ്ട് ആ ക്വസ്റ്റ്യൻ. 28 ഡേയ്സ് കഴിഞ്ഞിട്ട് എന്താണ് പോസിറ്റീവ് ആവുന്നത്?
അത് നമ്മളിപ്പോ പറഞ്ഞല്ലേ
സാർ, എക്സ്പ്ലെയിൻ ചെയ്തിരുന്നു. ശങ്കർ സാർ ഒന്നുകൂടെ ഒന്ന് പറഞ്ഞു കൊടുത്താൽ മതി.
ഹലോ
ശങ്കർ